Hi, my name is Dr. David Rubin. I'm from the University of Chicago. On behalf of CME Outfitters, it's my pleasure to invite you and to welcome you to the program that we've put together for patients called Who's in Charge, You or Your Crohn's Disease? I'm really looking forward to a conversation with my very good friend, Dr. Bruce Sands from Mount Sinai Hospital in New York City. Dr. Sands and I will be discussing management of Crohn's disease and, very importantly, an update on new guidelines that have been published related to the management of Crohn's disease. We both feel that it's very important for patients to understand these guidelines and certainly to understand the advances that have occurred in managing Crohn's disease so that you can take charge of your Crohn's disease, or if you're a loved one who has a family member with Crohn's disease or someone that you care about, you'll understand how to support them. And we hope that you'll find enough information during this program to have an informed conversation with your healthcare team and the people who are managing your Crohn's disease when we're finished. Let's get to the treatment part, which I know lots of people are waiting for and I'm sure we'll have questions about. So let's think a little bit about treatments for Crohn's disease. And I want to start by asking you something. I started off the program by mentioning that we're looking for a cure for Crohn's, or maybe more accurately, cures for Crohn's. In the meantime, why do we treat with therapies that are directed at our immune system? Why has that been the target of our therapies that seem to work?
Well, we've known for a long time, really for decades now, that the immune system is, for reasons that are only partially understood, overly active in the bowel. And while that would be appropriate if you had a bowel infection, that's the right thing to happen, the immune system should turn on. There's no demonstrated infection of the bowel and inflammatory bowel disease, and yet this inflammatory process is ongoing. And therefore, really, virtually all the medications that we have are directed at either turning down the inflammation, affecting the inflammation process, or turning down, adjusting downward the immune system. And that clearly is beneficial as an approach.
So let's move on now and review some of the treatments for Crohn's disease. Obviously, we could probably talk for an hour about each one of these bullet points.
But we won't.
But we won't be able to. But perhaps you can just give us an overview. And we have used the trade names for some of the drugs just so that our patients who are participating here understand what we're talking about. So can you just take us through the different classes of therapy briefly?
Right. So, you see here, everything above the biologics would be called more or less conventional therapies. These are older medications. These are all conventional medications in the sense that they're either pills, usually they're pills actually in most cases here. We start at the top with sulfasalazine, which is a very old treatment that dates back to the 1930s or 20s. And is really modestly effective for Crohn's disease, particularly of the large bowel, but it isn't very widely used and not very effective either. Steroids certainly have been used for many decades, and they are still helpful for some, but they do have some safety issues, as we all know, and they should never be used for long-term treatment of Crohn's disease. We have a more modern form of steroid called budesonide, which really works on the inner lining of the bowel, and very little of it is absorbed into the system, so the steroid side effects tend to be lower, so that was some progress. Antibiotics are sometimes used in Crohn's disease, especially in perianal disease or fistulas, or may also be used after a surgical resection of small bowel to try to prevent relapse or for different infections. And in children, it's not uncommon to use elemental diet, a more restricted form of a liquid diet, and for reasons that are also not perfectly well understood, that can decrease the inflammation. But the problem is it's effective when you use the medication, but once you stop using, not the medication in this case, but the elemental diet, when you go off that diet and you resume a conventional diet, the disease often relapses. Then we get what are called the immune modulators, and this would include the thiopurines, which include azathioprine and 6-mercaptopurine. These are pills. They have mild immune suppressing effects, and therefore they do have some side effects. Methotrexate, which is used in Crohn's disease primarily as an injection under the skin, but may at times also be used as a pill, taken just once a week. And then we get to the biologics, and these are newer medications in the last 20 years. In the case of the anti-TNF therapies, these would be Remicade, the first of them, and then biosimilars of Remicade, such as Inflectra and Renflexis. There's Humira, which is adalimumab, and Cimzia, which is certolizumab pegol. And we make our careers by pronouncing these things, and it's often easier for patients to remember the trade names, of course. Newer biologics would be the anti-integrin therapy called Entyvio, or generically would be vedolizumab. We do not use anymore Tysabri or natalizumab, even though it is technically approved for Crohn's disease. It has one very serious potential adverse effect. And finally, we have anti-interleukin 12 and interleukin 23 antibody called Stelara, or ustekinumab. And finally, we shouldn't forget that in some cases surgery is a wonderful option actually for patients with Crohn's disease.
So thank you for that overview. People are often confused or nervous about the term biologics. So I thought it would be helpful if we actually spent a minute explaining to the audience what a biologic is and what that terminology means so that we demystify it.
Yeah, so while the conventional therapies that I mentioned were at the top of the last slide are really chemical compounds, biologic therapies are different because they're actually made of proteins, not just chemical compounds that you can manufacture. These are not manufactured in the conventional sense. They're actually produced by living cells, and they're proteins. And the way most of them work is that all of these in this case are antibodies. Of course, your own body produces antibodies as a way of fighting off infection. The way they do this is these are kind of Y-shaped molecules, and the two tips of the Y very specifically bind to one kind of substance and help clear it out of the body. So in the case of infliximab, as an example, that's an anti-TNF antibody, and all it will do is bind to TNF and only TNF and help clear it out of the body.
So why can't they be taken as pills?
Well, if you took a biologic as a pill, our bodies are designed to break down and absorb proteins. Meats and other protein sources in our diet are digested, and you would end up digesting this very expensive medication, and it probably would not be effective for you in that way.
Yeah, that's the challenge. And just to drive home the point you made, when you use the term biologic, it refers to these antibody-type therapies. There's 3 different classes of biologics for Crohn's disease and for ulcerative colitis. And it's important to recognize that they're not all the same. They have different targets, they have different effectiveness, and they have different safety and different labeling. So it's important to keep that in mind when we go through some of this. So I'm going to go through a couple of the general principles of Crohn's. I'll do this part and then we'll hand it off. But the first point of managing somebody with Crohn's disease is to start with symptom resolution, make them feel better. We recognize, of course, that you want to feel better, and that's directly related to quality of life. The second part, as we've already talked about today, has been trying to get the bowel healed or look for objective measures that we've turned off the inflammation. That can be looking at all the different tests that Dr. Sands mentioned, or doing a scope or a scan. In children, it may involve making sure they restore their growth and development, which is very important. And we know when inflammation's turned off, kids will grow fast and they'll catch up, but it's a very important point. Then we look at customized treatment strategies, making sure that we're looking carefully at where the disease is located, how it behaves, and we recognize there's so many different types of Crohn's disease that often our treatment strategies need to be individualized and thought about in different ways. We choose our induction therapy not just on how sick the patient is, but on some of those risk factors related to their prognosis or likelihood that they might need a surgery or a recurrent surgery or have other complications. So we make decisions about treatments based on what we know about the disease location, its activity, and the prognosis. And then once we've successfully identified and used a therapy to induce remission, we have to identify a maintenance therapy. Because this is a chronic condition that can relapse or can progress, we want to make sure we choose a therapy that is effective for preventing the progression or preventing the relapse and is safe and tolerable over the time that we need it. It's a common question, am I going to be on this therapy the rest of my life? And the answer is most likely not. That's not what we're trying to do. And of course, we're making advances in the field. I've been telling patients for years that every couple years we have a major shift in our available options and the way we think about using therapies. So let's focus on getting you well and keeping you well now and define short time horizons. Finishing school, getting to your first job, getting married, having children, whatever those different goals are for you, we want to help get you to, and we keep reevaluating over time. And then very importantly, as Dr. Sands mentioned in the beginning, we want to make sure we continue to monitor. Recognizing that our therapies do work well in many patients, they also stop working in some patients. The natural tendency of any chronic condition is to drift away from control. It happens. Sometimes it happens also because we think the body is just trying to find a new inflammatory pathway. It is, after all, there to try and protect us, and the inflammation is the body's way of trying to protect us, or thinks that's what it's doing. So it's really remarkable that it develops redundancy and has new pathways. That's one of the reasons why we sometimes have to change treatments. And then lastly, and we'll come back to this, is the idea of prevention. Dr. Sands mentioned to you how we want to focus on avoiding complications. Vaccine preventable illnesses is important, monitoring the disease is important, and making sure you have a strategy to stay well once you're on your therapies. So that would include thinking about going to see your physician or your healthcare team or your advanced practice provider when you're feeling well. That's the opportunity to talk about all these other things as opposed to only having your doctor's visits or your nurse practitioner visits when you're not feeling well. We want to be able to have the time to review advances in the field and to discuss different ways to keep you healthy. So those are the general principles, and now I'm going to hand it back over to Dr. Sands to take us through some specific examples of how to apply the therapies.
Right. Well, so what was different in the ACG recommendations and the guidelines that were revised in 2018 was this notion of risk stratification. So for the patients who have lower risk Crohn's disease, meaning less likely to progress over time, are more on the mild to moderate side. There are a number of approaches which might involve simply treating diarrhea with antidiarrheal medications to make you feel better. Some of these are over-the-counter medications. There could be dietary modifications that may make you feel better as well. That usually has to be defined individually, really, because we can't necessarily predict which types of dietary items are going to make you feel poorly, but you probably can. But more importantly, if we are not treating the inflammation process because it's very indolent or very mild, we do still have to make sure that we monitor you carefully for disease progression. So we can't forget about that part of it. It's not just about treatment, it's about monitoring. And then if people have sort of mild, non-progressive disease, we might use sulfasalazine, which I mentioned, a very simple and safe medication. We might use a course of budesonide, this safer variety of steroid, for a limited period of time in most cases.
So the point here is if you think you have mild disease or you're told you have mild disease, whatever treatment strategy you decide on with your team, make sure that you're monitoring to know that the disease is under control.
Exactly.
And then let's talk about moderate to severe Crohn's disease, where there are lots of other options to consider.
Right. We have a lot of options, many more than we did even just a few years ago. And when we talk about moderate to severe Crohn's disease, again, we're talking about people who have a more serious prognosis, people who have the potential to progress to more complicated disease, narrowing strictures, fistulas, who are more symptomatic overall and just need more effective medications. That might include oral steroids for short-term use, but really not for long-term use because of their side effects. For those patients who are on steroids, it was still a recommendation to use potentially thiopurine medications like azathioprine or mercaptopurine, although we wouldn't use these medications to get the disease quickly under control. They may be effective in getting patients off of steroids and as maintenance therapies. Methotrexate in the same way may be effective for maintenance of remission and for steroid sparing, getting patients off of steroids. Thiopurines, again, for maintenance of remission, just like methotrexate. So those are the older approaches, and then the newer medications, the biologics, we have the latitude to use anti-TNFs to induce control of the disease, get it under control quickly, get patients off of steroids. We might use it for patients who have not responded to azathioprine or 6-mercaptopurine or methotrexate. We'll use it as maintenance medication as well. The other newer biologics, which would include vedolizumab and ustekinumab, can also be used for induction and maintenance of remission. And then there is one last recommendation, which is based on pretty good evidence that infliximab is more effective in combination with thiopurines than either single drug alone. And so that would be a very common and recommended practice.
So I can imagine this being quite overwhelming for our patients and their family members. How does the physician or the advanced practice nurse choose the therapy for the patient? What are some of the factors that go into making that decision? Or is it that people just work their way through one treatment after another?
You know, it is a complicated process, and it requires discussion and really a careful understanding of what the exact situation, and factors such as your age may go into it, the location of your disease and the severity of the disease, whether you have fistulas where some drugs may be more effective than others. And so it does require a lot of judgment and discussion with you. What are your values? What are your goals? And what are your concerns? And taking all that into account.
Yeah. And I think that the treat to target strategy that you explained so nicely helps us understand that whatever therapy we start in any situation, knowing that it's working and then moving on if it's not, is a helpful algorithm.
And sometimes adjusting treatment is also appropriate, because we may start at one dose with a medication and find you need a higher dose of the medication. Absolutely. Or more frequent dosing, and that may be just all that you need, not a complete change.
And one of the things that's influenced our choices of therapies has been the understanding of safety, both short-term and longer-term. And we have this pyramid of safety here that maybe you can explain a bit to us.
Yeah, the notion here is that the things at the bottom are the things with the greatest level of concern for side effects. And really at the bottom, boxed in red appropriately, are the steroids. While we do use steroids, and they are still helpful and sometimes necessary, as we've said repeatedly tonight, we don't want to be using these chronically. These are not long-term treatments, and we know that there's an increased risk of infections and even an increased risk of mortality with long-term use of steroids. All the other things have acceptable long-term use. That includes at the bottom thiopurines and anti-TNFs in combination, but there are some concerns of infection and some rare kind of low risk of lymphoma, for example. Thiopurines and tofacitinib, which is really not used in the treatment of Crohn's disease but is used in ulcerative colitis, have a little bit less in the way of risk, so we're talking about one individual therapy. If you use single therapy of anti-TNFs, that is probably safer but not always as effective as combination therapy with thiopurines. And then finally, the newer biologics probably have the best safety profile, and these are vedolizumab and ustekinumab, which really don't seem to have increased risks of infections or of cancers.
And the reason for that, we think, is because of the way they target primarily where the inflammation is, and they don't affect the rest of the body in the same way.
That's right.
So those have certainly been some nice options that have become available. So one of the next issues, and we've mentioned this a couple times, has just been once the patient's in remission, the importance of monitoring. As much as you're relieved that you're feeling well and maybe you've been told your inflammation is shut off, we have to recognize the importance of ongoing monitoring, both to know if the disease is starting to relapse, as well as to, of course, keep an eye on how the therapies are working. And we know that things change over time. Bruce, you've already nicely mentioned the stool tests and the blood tests. So we'll move on, except to remind people that the purpose of maintenance therapy is to prevent relapse after you're already in remission. So if you stop the maintenance therapy, you might feel well for a little bit because you're in remission. But the natural tendency of a chronic condition will be that it will relapse. So we're always trying to figure out what's the least amount of medicine we need to keep someone well and to not put them at risk of disease progression or other complications. So what do patients with IBD say about understanding monitoring? We actually asked them, and we have an example here from Wendy.
I call and I am having any type of symptoms, she will order labs, and I know that she is looking for specific markers. I never have discussions with her about what the markers are specifically that she is looking for. I wish that I did have a better idea of what it is in the labs that she is trying to get.
So hopefully now we've laid out for you the importance of some of these tests, and it might be helpful for you the next time you're seeing your team to know why they're ordering certain tests. Is this to monitor your therapy, or is this to monitor your disease, or both? And what are they being used for? So the next brief point that we're going to talk about is just the last issue, which is you're finally on a therapy, it seems to be working, you're doing everything that you're supposed to do, and now the treatment has stopped working. So Bruce, just briefly, tell us why therapies stop working. It's a very frustrating problem for all of us.
Yeah, what an awful feeling. You're feeling well, and then all of a sudden you're not feeling well, and you're still taking your medications, which, by the way, is maybe the first question that your doctor will ask you, because as Dr. Rubin pointed out, one of the main reasons that people may flare is because they simply stop the medication because they're feeling well and don't understand that they have to keep taking medication. But assuming that's not the case, it's not your fault. The body will find ways of manifesting inflammation through new pathways that aren't addressed by the medication that you're taking. That's one explanation. It could be that you've developed an infection on top of the Crohn's, that you have some bowel infection that you've picked up somewhere, and that does happen. Unfortunately, that sometimes not only causes symptoms at the time of the infection, it can also trigger a bona fide flare of the Crohn's disease. And then for biological therapies, they're wonderful therapies, but one of the issues is because you're putting in a foreign substance of a protein into your body, your immune system actually has the potential to react to them and form your own antibodies, just like you react to a vaccination. And that then makes it have low levels of the drug in your blood because it's being cleared out quickly and you can't respond to the drug anymore. The last one, if you stop taking the medication, then obviously we do understand the reason for losing response.
Well, we've certainly learned about some ways to minimize this. One of the ways to prevent loss of response is to get on effective therapy and control the disease earlier in the disease course. That seems to be predictive. The other is to make sure that the therapy you're using has been optimized or is being monitored properly. So there are some steps patients can take to try to make sure that this doesn't happen as often, because obviously we don't want that to occur, and it's a big challenge when it does. The good news is we have more therapy options than ever before, and so sometimes making a switch is a good thing. So what do you do when the medicine stops working? What's the approach that our patients should know about?
Well, as we said earlier, even though you have symptoms, it doesn't necessarily mean that you have inflammation. So the first thing that we'll want to do is confirm that there is inflammation in the bowel. That might be with a marker in the stool or the blood, or we might go so far as performing a colonoscopy. We will probably rule out a bowel infection. That means submitting a stool specimen probably. If you're on a medication, a biologic in particular, where we know that you need a certain amount in your blood, a certain drug level, we may check that level and make sure it's in range. And if it isn't, we might actually boost the amount of the drug. We might change the dose if the drug level is too low, or shorten the frequency between doses, which is another way of changing the dose in a way. We might add another medication. Maybe in the short term, we might give you a course of steroids just to get the inflammation cooled off, and then hopefully you'll be okay again. But if we really think that you're no longer responding to the medication at all, we will probably switch you to another medication, either of a different type altogether or sometimes the same sort of medication.